Pemetrexed maintenance has been studied in non-small cell lung cancer previously, and there clearly was progression-free and survival benefit with the use of pemetrexed maintenance after a platinum doublet. So the KEYNOTE-189 trial builds off of that, where it just adds in pembrolizumab to the pemetrexed maintenance. And clearly there was a PFS and overall survival benefit. So we certainly advocate to give the pemetrexed and pembrolizumab as maintenance therapy. Now, if a patient has an autoimmune adverse event, you could certainly drop the pembrolizumab, or if they certainly have toxicity from the pemetrexed, you could continue pembrolizumab maintenance therapy. The regimen of the triplet with the carboplatin, pemetrexed, pembrolizumab, usually I will give about 4 to 6 cycles, and it really depends on the patient's response. If they are still shrinking dramatically after 4 cycles and their performance status is still good, I will go to 6 cycles of therapy. But if they plateau out, I usually stop at 4 and just go to maintenance therapy. In the case of how long to give these treatments, so the prior studies with maintenance pemetrexed continued until patients developed progression of disease. We don't know how long we should be giving pembrolizumab maintenance therapy. Some studies have shown, perhaps in other tumor types, that 1 year or 1.5 years may potentially be enough. So in KEYNOTE-189, they gave pembrolizumab for a total of 35 cycles of therapy. So we currently do that in clinical practice, but there are trials ongoing right now to determine what is the optimal time frame to give the maintenance pembrolizumab and pemetrexed. The triplet regimen can be tough to give, so you do have to give it in a patient that has a reasonable performance status. But by this, I do include PS2 patients if they are PS2 because they have high disease burden. In patients who are in very good health, who really just have their cancer, but they just have a lot of it, this is certainly an appropriate regimen to give. The platinum pemetrexed backbone is very well tolerated, and we have that data. And again, the addition of pembrolizumab to this does not significantly increase toxicities. If you look at the KEYNOTE-189 trial, the grade 3 adverse events were pretty equivalent between the 2 arms. There was a slightly increased risk of rash and diarrhea, which are typical autoimmune events, as well as febrile neutropenia. And then I do always caution patients that there could be some kidney toxicity, slightly higher, 5% versus 3%. But certainly this is a regimen that's very well tolerated overall and does not appear to have too much additional toxicity beyond just a platinum doublet. Adding pembrolizumab to chemotherapy does appear to increase rash, diarrhea, febrile neutropenia. These are to be expected. The pembrolizumab is a checkpoint inhibitor. It stimulates the immune system. And as always, you have to watch for any type of autoimmune reaction. I usually counsel patients that you can get any type of itis, so any inflammation anywhere in the body. Typically with checkpoint inhibitors, you have to watch the thyroid function. They could get hyperthyroid or hypothyroid. Those are usually the most common adverse events, including rash. And also, you could get a small percentage of colitis as well. Now, in terms of management, it is very important for early detection. So education of the patient is crucial, because the minute that they develop an itis, we have to monitor it. If it is something like a rash, you could do topical steroids as long as it's not very severe. But if it does progress, you do have to give them systemic steroids, and you have to hold off on any immunotherapies. Also for colitis, this is very important to make sure the patient stays hydrated. And also, I have a very low threshold for initiating steroids in this case. There are treatment algorithms that are posted online for all of the checkpoint inhibitors that can be followed. In terms of febrile neutropenia, I have given Onpro as a protective agent for my patients who are receiving the triplet regimen to decrease their risk of febrile neutropenia. I sometimes will do this prophylactically in our patients who I think are at higher risk of this. And then in terms of renal toxicity, hydrating the patient, educating them that they have to stay hydrated is very important. And usually you have to check their labs before every single treatment, and you can pick this up pretty quickly. In KEYNOTE-189, there was no increase in percentage of patients who had grade 3 or more toxicity. It was pretty equivalent. There was a little bit of a difference between the side effect profiles. Obviously, you get more immune-related events. So rash, diarrhea, febrile neutropenia are the ones you watch out for. And then there was a slightly higher renal toxicity. But beyond that, It was very well tolerated, and there was nothing too significant with that regimen.